This very important symposium is conducted in collaboration with SLMA, WHO, World Bank, and the Ministry of Health. I'd like to invite my co-chairperson, Dr. Jayasundara Bandara, to introduce the first speaker.
The first speaker, Dr. Miki Chopra. First of all, I just have to announce that this is past midnight, past 1 a.m. for Dr. Miki Chopra. But still he's up for having identified the importance and the interest for this symposium. Dr. Miki Chopra is currently the Global Solutions Lead for Service Delivery in the Health, Nutrition and Population Global Practice of World Bank. He leads its work around the organization, management, and quality of health services. Previous to this, he was the Chief of Health and Associate Director of Programs at UNICEF's New York headquarters, leading the agency's work on maternal, newborn, and child health, immunization, pediatric, HIV/AIDS, and health system strengthening policy and research. Additionally, he has chaired the evaluation and research group at the Global Fund for HIV/AIDS, TB, and malaria to ensure that their investments are reaching those most in need, and chaired the Special Committee for Large Countries for Gavi that worked on ensuring increased coverage of vaccines for Nigeria and India in particular. Dr. Chopra is qualified as a medical doctor with an additional degree in medical sociology from University of Southampton, England, Masters in Public Health, Primary Health in developing countries at the London School of Hygiene and Tropical Medicine in 1977, and a PhD from Faculty of Medicine, University of Uppsala in Sweden. Dr. Chopra has published over 200 international peer-reviewed papers and contributed to numerous book chapters concerned with international child health and nutrition. Moreover, he was one of the pioneer technical experts in designing and planning the primary healthcare system strengthening project in Sri Lanka funded by World Bank. Dr. Chopra, the forum is now for you.
I'm going to talk about 4 clinical insights, and I'm going to suggest 5 systems shifts, and then provide some examples of some of the cutting edge innovations that's going on. Hey, you might have some trouble. The first insight, the clinical insight, has been that health systems matter. And this graphic shows you the early on in the epidemic, in around April, this study was done. The vast difference, both in, particularly in the case fatality rates for COVID-19. And I just wanted to show this just to make the point that even in the most advanced systems, there can be quite a variety and variability around the case fatality and the quality of care provided. The second insight that we've gained from COVID in the clinical sense has been that outside of the immediate clinical issues, there are a number of key challenges that we've recognized that are needed in addition to the capacity and training of health workers, in particular the supplies of protective equipment, as well as key inputs such as oxygen and ventilations and so forth. So it's not just the clinical competency of the health workers, but it's also some of the key supportive systems which have been absolutely found to be essential in responding to this challenge. Another key insight we've recognized is this slide shows you the thorough assessments which were done before COVID, were done last year, looking at what we call the Global Health Security Index. And just if you look at the far left, you'll see the top 2 countries were assessed through a very rigorous technical process were United States and United Kingdom. And actually, these are the 2 countries that have done almost the worst in the world in terms of managing and responding to the COVID outbreak. So this index measured, policies, it measured lab capacity, it measured clinical competency, public health capacity. And so what we recognize has been that it's not just about having the technical inputs and the infrastructure even, it is also about leadership and decision making and clarity of leadership and evidence-based decision making as well. So we've got to be thinking beyond the usual inputs type of way in which we've done work in the past. And then the final insight I want to share, immediate one, has been the resilience of systems. This is just an experience from the Ebola, but we're now seeing this, unfortunately, with COVID as well, that the non-COVID essential services are also suffering. And this is just a study that was done in Sierra Leone, showing that the number of cesarean sections, for example, even after the Ebola outbreak had finished, did not get back to the same levels as before the Ebola because of the loss of trust and the loss of health workers in the system. So there are now some estimates that the deaths happening due to non-COVID are exceeding those because of COVID, because of the lack of care and the breakdown of trust in some settings as well. So the ability of the system to continue functioning even when having a shock is another essential component and characteristic that we must think about more as we move forward. So let's shift now to what changes are we seeing as a result of COVID, and that can have importance and relevance for Sri Lanka as well. And I want to suggest 5. The first thing we're recognizing is that we must start to think about the provision of healthcare to be more distributed. So in other words, it must go beyond just the fixed facilities and think about how do we do more on the self-care side, look at workplaces, and also countries which have coped well have engaged with a wider range of cadres of workers, community health workers, contact tracers, and so forth. So we must think about how to distribute care more widely. We've got to think about how to get more connected, and the countries which have succeeded the best, the South Koreas, the Chinas, and so forth, have had at their bedrock a very strong data system and an ability to triangulate and bring together different data sources for both management but also for public health functions such as contact tracing. The third shift that we're seeing is related to the first one, and it's really about healthcare serving people 5,000 waking hours as opposed to the only 15 minutes they spend in a fixed facility. So in other words, keeping in touch with patients on a continuous basis, the use of telemedicine, the use of digital tools are all proving invaluable, both in keeping people healthy and keeping them out of the healthcare system unnecessarily. This is centered upon the fourth shift, which is we're seeing a more acceleration of the recognition to make healthcare more human-centered, to put patients and their caregivers at the heart of the planning and the way in which we think about delivering services, and to empower health workers to do that. And then finally, successful systems we're seeing are being very responsive, and that they're adapting to the new data. They are able to, through gaining the trust of their populations, able to change messages when the evidence changes and change behaviors as well. So I'm just going to give a few examples of how these shifts are playing out, and then, like I said, I'll finish with some reflections on what this may mean for the project and the work in Sri Lanka as well. So the first thing we've seen now in successful systems which are coping has been that they've recognized that they cannot deal with everybody at the same time with the same intensity. And what's been interesting to see the high mortality rates in the UK and Sweden and even in New York and New Jersey was that they hadn't segmented their population and focused on the most high risk, particularly elderly. So you may be aware that the high mortality in the elderly care homes was a big cause and driver of high numbers of deaths. And so there's been widespread recognition that the need to risk stratify your population and then to design your interventions. You'll see on the left side of the slide some of the ways in which the design issues are coming in, so that we focus and target and make appropriate investments at the right levels, depending on the segmentation of the population. Now, this is important. This relies on the bedrock of solid analytics, looking at data more rigorously, and also having integrated data sets that can talk to each other and be integrated with each other. This has relevance post-COVID, as many of you will recognize, for non-communicable diseases in particular. What we're also seeing is the more widespread use of an integration of digital tools to help in this process of more integrated and continuous management of patients. This is just one example of an application which has taken off, particularly here in the US for diabetes. And it's a tool which is being used to monitor high-risk patients in their homes, and is found to reduce the number of admissions as well as the number of face-to-face consultations required for those who are on the platform. But what's most important is that the application by itself is not, those examples are not proven to be very effective. It's only when you integrate it into a more holistic ecosystem that we see the real impacts of digital health. And so this is just one example of the Veterans Health Administration here in the US, where in some settings they've now started to look at how to bring together different tools, both the traditional, but also now with data integration and monitoring tools in the home, so that you almost have a hospital at home, as they call it. And so they're now doing a lot of monitoring of patients in the home. They can discharge patients from the hospital much earlier and much sooner, and therefore reduce the risk of hospital-acquired infections, and also the morbidity associated with travel and getting to see the doctor and so forth. So I just want to emphasize here that it's not just one app or one phone app that will make the big impact. It's when you start to pull things together into a more holistic service that looks at the different needs of patients and brings them together. This is another example of this from China, where, as you know, in China, they have a big challenge of the hospitals are physically overwhelmed with long lines, long queues, people lining up from 3, 4 in the morning to see the specialist. And so they really are now making a huge push towards getting the specialists to be accessible in the rural areas and outside of the physical hospital, through a very comprehensive internet and telemedicine approach that they're taking, and they're starting slowly to see some results from this as well. So this is not just happening at a small level, this is starting to happen at quite scale as well. I just want to finish with a case study of a group that has just come public here in the US called Accolade, and I just wanted to show you how we can start to use the COVID outbreak as an opportunity to bring these investments together and really both respond better to COVID, but also lay the foundation for a future system as well, a more improved system. So this is a group which has got particularly brought 3 elements together. One is that its members, so this is a cooperative group of patients who joined this group, and the members are all connected by a mobile phone, and they're receiving information and two-way communication with providers through their mobile phones. Their health workers are also getting regularly, daily updated guidelines and clinical support as well. And then they are doing using big data analytics to look at patient journeys to see where they can get efficiencies and better quality of care based on all the data that's coming through from the thousands of patients that are now going through the system, to see what oxygen saturation levels is optimal for reference, what can be done in a home care based setting, even as the oxygen saturations drop, what symptoms are more predictive of morbidity, and then they're feeding that data back into the protocols from the healthcare workers in real time, almost on a weekly basis. They're adapting their protocols based on the data they're getting back from their systems. So this is an example of connecting different pieces together, but you need a bedrock of an information system and data analytics, as well as then educated health workers and a responsive client as well. Just to give you some of the examples, just this slide is just showing how, and it's not all high tech, it can be very simple messages, but it's tailored for the patients. So those who are high risk, because they've got pre-existing conditions or they're elderly, are getting different types of messages versus those who are lower risk. And like I said, there's real-time learning going on as they look at their data all the time. One thing I want to emphasize here as well is that all of this software is available globally. It's something that Sri Lanka, you have computer scientists and your data scientists have this capacity. We've been working with them through the World Bank project as well. And so this is not just something which is happening in the Western countries. As this capacity is available in South Asia, India, and Sri Lanka for sure. Yeah, just a couple more points here around how they are not just looking at individuals, but also looking at the big data side and monitoring the performance of their clinics and their clinicians across the country, and seeing and looking for why are some centers doing better than others, and what can they learn at the meso level, if you like, as well as what's happening at the micro patient level. So it's not just looking at the individual level, but also doing analysis at the clinic and district level as well. Okay, I'm going to finish just with some reflections on what does this mean potentially for Sri Lanka. I'm not an expert, you're the experts, but just from my vantage point as just to start the conversation. I do believe that you have the capacity and you're already well on your way with national information systems. What's missing perhaps is the integration of different types of information systems. So for example, the hospital clinical information system doesn't speak to the laboratory information system, which doesn't in turn speak to the primary care information system. So these are things which are fixable, but do require some work and some political leadership to achieve. And that's something the SLMA is well positioned to contribute towards. I think the key thing here as well is that we mustn't separate clinical care from public health. That what we've learned from this outbreak is that the clinical information can be just as essential for public health surveillance as the traditional door-to-door work that we do as well. And yeah, the potential to make sure that we spare the hospitals and we don't fall into the trap of, because of the stress of COVID, of just focusing in on the hospitals, that there's a lot we can do in the community and in the primary care level, which can make sure that the hospitals don't become overwhelmed and they don't become centers for infection and spread of disease themselves as well. One of the lessons we've learned from Italy, as well as some places in the US as well, is that actually the hospital and the experience from China early on was that it was a hospital which was the super spreader events, and as healthcare workers in hospitals who were spreading the virus in the community. So how do we keep patients out of hospitals and managed at the appropriate levels is a key challenge moving forward. And then finally, we can improve quality of care through the use of AI and better communication with our frontline workers, and that's been shown to be done in Sri Lanka as well. So I'm going to stop there and really thank you for your time, and I hope you're able to do the presentation clearly.
Yes, thank you, Professor Chopra. Now the forum is open for discussion and questions. There can be questions from the in-person audience, or if the online participants have a question, they can either message or they can raise their hands. In the absence of questions at this moment, we will move to the next presentation. Thank you, Professor Chopra. We would appreciate if there's a possibility for you to stay a little while towards the end, but we understand that it's very much late in the USA. So in the interest of time, we'll move to the next presentation. That's regarding NCD, management of NCD in the COVID era. And the presentation is by Dr. Vindya Kumarappeli, who is the Director of Non-Communicable Diseases in the Ministry of Health.
Good morning. First of all, let me thank SLMA for giving the Ministry of Health this opportunity to do the presentation. So I will be talking about the impact of COVID-19 with the policy implications for NCDs, and I would briefly present the NCD burden, challenges we face during the COVID-19, and how we maintain the NCD-related services, and some innovative approaches which have policy implications. So as you all know, Sri Lanka has a high burden of NCDs, and NCDs are estimated to account for 83% of all deaths in the country, and premature deaths accounting for 17%. If you look at the main 4 risk factors, the NCD risk factors are also fairly high. So, according to the WHO Rapid Assessment Survey on service delivery for NCDs during this current pandemic, many countries are faced with severe disruptions in their preventive and curative services for NCDs. However, taking measures to avoid interruptions to NCD services was crucial because people with NCDs are reported to suffer worse morbidity and mortality due to COVID-19. And many patients who were taking treatment for NCDs were unable to visit the hospitals due to restrictions on travel and poor availability of transport, as well as measures taken to avoid overcrowding at hospitals, which resulted in disrupted regular clinic schedules and consultations. So one of the main challenges was the less accessible NCD services for preventive, curative, and palliative services, that is, less access for essential medicines, investigations for clinic patients, and provision of in-ward and emergency services, as well as screening and lifestyle counseling at healthy lifestyle centers, and the service we provide for palliative care, home-based services. And second one was difficulty in maintaining a healthy lifestyle. It's not only limited to NCD patients, but for general public as well. Because of the lockdown we imposed and our constant reminders to stay at home, people became sedentary with lack of physical activity and unhealthy eating. Then we had to postpone our routine capacity building programs for staff, as well as monitoring and supervision of NCD service provision. This mainly affected training of primary healthcare staff on NCD management guidelines and also training on lifestyle modification. Therefore, it was necessary to prevent a second wave of deaths due to an epidemic of NCDs, and maintenance of NCD-related services was identified as a priority in the National COVID-19 Response Plan of the Ministry of Health. So, firstly, let me explain how we ensured continuous supply of medicines for NCD patients on long-term care. For those who were taking medication from government hospitals, we issued medicines for longer periods, sometimes 2 to 3 months, compared to the routine method of issuing for 1 month. And there were measures taken to deliver medicines to the doorstep of the patients through the Department of Postal Services or through healthcare staff as well as non-health staff, village leaders, volunteers, etc. And some of the secondary and tertiary hospitals provided medicine, especially insulin and depot injections, to the nearest primary care center. And of course, we need to have an updated patient detail at the hospital. Unfortunately, this was the main challenge, and as a result, the Ministry of Health published the clinic contact numbers and requested the public through mass and social media to contact the clinic and provide the most updated residential address. And as we know, there are patients who are followed up at the private sector or could afford to purchase from private pharmacies. For them, we introduced a web-based mechanism and to deliver medicines in collaboration with the Pharmacy Owners Association. Of course, these pharmacies had to be approved by the NMRA, and guidelines were issued by the DGHS to make sure quality was controlled. The public had the choice of selecting pharmacy through the MOH website, then submit an image of the most recent prescription through WhatsApp or Viber to the pharmacy, and the medicines were delivered to the patient, charging an additional delivery fee. Then what about provision of inward and emergency care? These were uninterrupted, but unnecessary admissions were discouraged, and patients were educated on danger signs widely educated using mass media and social media, so that unnecessary admissions were discouraged. And we somehow managed to maintain the essential home-based palliative care through the public health nursing officer. And we heard a lot from the previous speaker, Dr. Chopra, about digital solutions. We also introduced some digital solutions. Telemedicine was one, established at 16 nephrology clinics in government hospitals, especially to respond to questions from patients with kidney transplant or dialysis. And here we used the My Doctor telemedicine system through funding from private sector organizations, and consultations were done connecting the patient through their mobile phone while at home. And at the National Hospital Kandy, we also had introduced another pilot project, and it's being implemented with support from WHO and a private sector organization, where we network the National Hospital Kandy with secondary and primary care hospitals in the central province, and the patients will be connected at the hospital closest to their residence. So we cannot forget about patient information services, especially during a lockdown period. I think Dr. Chopra also mentioned about the importance of informing the patients. So we established trilingual helplines for the general public, and professional colleges also maintain separate hotlines for patients. And again, we used mass media and social media for these messages. So, promotion of healthy lifestyle for patients as well as the general public was another challenge. And again, we used mass media and social media and electronic media especially to disseminate messages. And with support from WHO, we distributed 1 million leaflets along with the doorstep delivery of medicines that we introduced. As I mentioned earlier, capacity building was very important. Now we are in the process of establishing virtual learning management system, where the NCD Bureau would be the central hub and connecting 9 provincial teleconferencing units via Zoom technology. And again, WHO is supporting us for this, and this will be for capacity building, especially for medical officers at the primary level, and also for monitoring, that is conducting quarterly reviews. So what are the policy implications? There were many innovative public health approaches implemented during COVID-19, which can be adapted into policy options in the future. The multisectoral approaches ensured that patients as well as the public had access to essential NCD services at a time NCD services were disrupted globally. So medical supplies is one option we have to consider. Issuing of medicines for 2 to 3 months. Of course, this has to be in blister packs, and the consultants will have to decide whom to issue medicines for longer periods. And then delivery of medicines from the nearest primary care hospital. I think we talk about the primary care reorganization project supported by the World Bank, so that we have to strengthen and expand it. Then use of field staff for doorstep or rather home-based care for NCDs. As we know, there is no designated primary care worker for NCD home-based care. So this is one policy option where we have to get the support of the field health primary care workers to deliver home-based NCD services. And the online deliveries of medicine that I mentioned earlier is a very good example of partnership between private and state sector. And I hope it will continue to thrive in the future to serve patients who desire to utilize this service. And Dr. Chopra also mentioned a lot about digital solutions and telemedicine. So we will expand this to other hospitals as well, which will prevent overcrowding and minimize unnecessary clinic visits, and also very useful for high-risk patients or immunocompromised patients. Another digital solution that we have to consider is digital tracking. As I mentioned earlier, absence of patient records in clinics as well as personal health records, electronic ones, was a major challenge. And we are implementing this at the Teaching Hospital Kandy, and the World Bank project, the Primary Healthcare Strengthening Project, also supports these personal health records and issuing a personal health number. With WHO support, we are implementing this as a pilot project in Teaching Hospital Kandy, where the patient records in the clinics, personal health records will be linked within the hospital as well as with the peripheral hospitals. And this is very important to facilitate tracking on referrals and follow-up. And we plan to do cohort monitoring to reduce lapses in continuity of care. As I mentioned, another digital solution is e-learning, and this will increase health staff access to training and education to overcome geographical barriers and travel time, and maximize most recent educational material, and also to establish continuing medical education. Of course, these will have to be done according to the e-health policy of Sri Lanka of the Directorate of Health Information. And I think we talked about this use of social media, mass media, and digital solutions for IEC. So here there are so many examples, and Dr. Chopra also mentioned about use of mobile apps. So we plan to use digital solutions for patient education, communication, especially for follow-up, using voice messaging, text messaging. And here again, we have another project coming with funding from the Resolve project and WHO's technical support. Finally, we should not forget health promotion. As we all know, during the lockdown period, there were so many good health promotive initiatives adopted by the public, and home gardening is one thing. And I think home gardening is mainly livelihood oriented at the moment. We have to make sure that it's nutrition oriented, where we promote consumption of more fruits and vegetables to reduce obesity. Thank you.
Thank you, Dr. Vindya Kumarappeli, for that very informative presentation. Now, the forum is open for discussion. You can ask questions from the audience also. Yes, Dr. Sajid, here.
Madam, I would like to ask, now you mentioned about the pharmacy, the drug delivery system. Do you have any feedback or the assess of how success we are, and the accuracy, and how many people have used it?
Thank you. Yes, we conducted a survey with the support from CDC, a telephone survey, and we have actually gathered information from 5,000 patients, and we will publish it very soon. Yes.
Yeah, it was a good service because even my parents also use that.
Yes, we will publish it very soon. I think we'll be presenting it at the College of Community Physicians sessions. Thank you.
There is a question coming from the online audience. The question from Dr. Arulmoli. Does the Ministry of Health have any initiatives to use human resources in curative institutions, which is higher in number, compared to preventive care during the lockdown optimally? Do I need to repeat the question?
So he's asking whether curative staff was mobilized for preventive services.
I suppose that's a question.
Yes, so actually, Indika, it's the other way around. I think the public health staff, especially the midwives and public health nursing officers, were mobilized to provide the COVID-related patient tracking and then self-quarantine advice, etc. So it's the other way around that happened. Thank you.
Right, when I point out
Yes, madam.
this problem is there with the PHIs that we used to call them sanitary inspectors, but they have not been given real thing, and the uniforms are also not in that sense, but they have a real thing now. They are not, they did a lot of service with their things and they are unaccounted for.
Yes.
Whereas the nurses and the doctors have been complimented and things, and the police and the army people have been
Yes, madam.
given
I think,
recognition. They are far more important because HLMA itself, in the regular service, we needed mainly a male component. I think HLMA pointed that for community work.
Yes,
A
madam.
male, about 2 or 3 years ago, we pointed that missing male for community service.
So actually, we noticed that they played a huge role during the COVID epidemic for communicable diseases. But we would really, as a directorate, would like to really use the PHIs for NCD work as well. I think they can play a major role in terms of NCD prevention also. I think it's an important category in our public health team, and we should acknowledge that.
Then again, you mentioned about the need for capacity building and the online learning. And SLMA and WHO, also the World Bank and the Ministry of Health, together we have done a lot of work related to CPD. And this year, one of the priorities is CPD. And because of the COVID situation, now we have been pushed into online learning and also the online continuous professional development, which can be a blessing in disguise. Can I ask Dr. Deepika Artigal, who has been spearheading the WHO project, and also Dr. Miki Chopra, to tell few words about the initiatives related to online learning?
Thank you, Professor Indika. I think, yes, as you mentioned, now listening to Dr. Chopra's presentation and Dr. Vindya's presentation, I think, of course, with the COVID, we are coming to a new normal rather. So e-learning or the continuous education and the things we do are a bit different than what it was previously. Even the whole session is virtual basically. So I think World Bank is very much interested in supporting the government to strengthen those distance education methods or the mechanisms, so that the capacities of the rural doctors as well as the other staff members will be strengthened through those new methods. So I think the SLMA is leading the main role in implementing this distance education teaching methods to the primary care doctors to enhance their capacities. So I am sure that with the support of the WHO and the other development partners, we can make a big kind of make a mega picture of this distance education with your support, with your leadership from the SLMA, so that the people in this country will benefit enormously while doing their routine work, so they will be able to access those new knowledge, as well as the kind of in-service training that we have been doing, coming to Colombo and spending more time with our own time as well as with the staff of the trainers. So this method will be a real, I would say, a felt need of the country where we support, and the government will take the lead to expand to the other provinces as well. Thank you very much.
Can I add something, Indika? I think I also mentioned about CME. I think SLMA can join hands with the Ministry of Health, because we really want to promote CME points where it's not mandatory in our health system, but if we collaborate with SLMA, at least we can, that would be a big step in medical education. Thank you.
Yeah, actually, if I may come in, I mean, the plan should be, the leadership should be from the Ministry of Health. The Ministry of Health should dictate what's a CPD platform for the whole country, and it should be based on the needs of the ministry. And if the doctors can show evidence from whatever platform that they are using, that they have done the completed CPD and achieved the competencies, then if the ministry can certify them, and maybe if they can give some incentive, maybe a grade promotion or maybe a salary increment, that would be a very much way forward towards CPD. Because at the moment we have been somewhat struggling to get the participants in. We have put the platforms in from ministry, from the World Bank, from WHO, but getting the participants in is a challenge. So I think that should be one thing that we have to be really focused on.
Yes, I like to add, we are launching our cardiovascular module with WHO very soon, and that is basically targeting CME. Yes, thank you, Indika.
Just before we finish this presentation time, and lastly, this is with regard to the recognition of the contribution made by the PHIs in this COVID-19 management. I think the government has really recognized the contribution made by the PHIs in managing this whole problem. In fact, these PHIs who were not given a motorcycle for the last 6 years, now this through the World Bank project for COVID-19, all the PHIs will be given a motorcycle to recognize their contribution. Say in another 3 weeks or 4 weeks time, they will get their motorbikes.
If I can point out, I think their designation was the main problem. They were called sanitary inspectors. So that is the thing. Whereas the midwives were midwives, and they are part and parcel of the thing. These people went to find sanitary and to report on lack of things. So what they did was just, not comprehensive, getting into the NHS services to the. I have pointed this out, and I think that's what they are praying for also, because they are not accepted as people.
So thank you. So a lot of good discussions related to two very important areas. One is related to the human resources in health, one related to the CPD. Before we move into the next presentation, I would like to get one comment from again Dr. Miki Chopra. I think we should not be keeping him too long, but since you are discussing about the online learning and the CPD programs, and he was very much involved and very supportive related to the CPD programs that were conducted and that were implemented. Maybe one final comment from you, Dr. Miki Chopra?
Much, and it's very exciting to see the work with SLMA and WHO and the bank together to get this program. But as you mentioned, we must look carefully both at the demand side and how do we incentivize health workers doctors to take part and be fully engaged, and secondly, not to just stop at the traditional what we've done so far with the distance learning, which is important but not sufficient. And as I mentioned, that we can now have more, as doctors and nurses become more comfortable with the distance learning and using of technology, how do we in real time update protocols, give them feedback on how patients are doing, referrals, what's happening with their referrals, and so forth. So use this as a stepping stone for a more comprehensive and integrated information system and clinical care system that's possible now with the new technology. Over. Thank you.
Can I ask my co-chairperson, Dr. Jasundara Bandara, to introduce our next speaker?
Thank you. The next presenter is not strange to the Sri Lankan audience. Dr. Razia Pendse, the World Health Organization representative in Sri Lanka, Pendse now took over as the WHO representative to Sri Lanka in May 2017. Dr. Pendse, who is a national of India, has been with the WHO since 2004. She has held various positions at WHO Regional Office for Southeast Asia and WHO headquarters in Geneva. She has over 20 years of experience working in the development sector, is passionate about promoting health and well-being for all, and aspires for an equitable, peaceful and sustainable world where no one is left behind. Dr. Pendse received her Doctor of Medicine in Pediatrics from the University of Rajasthan, India, and Masters in Public Health from University of London, UK. So the
Andhra Bandara. Good morning, everybody, and good afternoon, good evening to all those watching online in this physically distant yet digitally interconnected conference. And I would like to thank SLMA for taking the initiative of organizing the sessions despite the COVID lockdowns and travel bans. And thank you, Professor Indica, for inviting WHO to present on a topic which is not my comfort zone. Maybe that's why he gave me this topic. But nonetheless, it's very, very important and critical. So the topic that has been given to me is to talk about migration. So what does migration mean in the time of COVID-19? So this is just a kind of a snapshot. I've picked it from a World Bank report. And this states, starting from the Spanish flu of 1918, and from there various pandemics that have come in, be it SARS or H1N1, MERS, Ebola, and now COVID-19. And it just gives a snapshot of what proportion of the world population is impacted by the disease, the deaths, the case fatality, most affected countries, what is the proportion of population that has been affected, and what is the change in the GDP as a consequence of the pandemic. What is important is that this is a pandemic. It's once in a lifetime pandemic. It has impacted lives and livelihoods. And if we look at the global financial crisis of 2009, the change in the GDP in the high-income countries was downwards of 3.7%, while the lower middle-income countries had a plus minus 3.3%. If you look at COVID-19, it is negative 8.7%. This report was in April 2020. And as of June 2020, the outlook still stays grim at a negative. We are looking at a deepest economic recession, and it could last decades. And it is one of the worst in the last 8 decades. This economic crisis could be long, deep, and pervasive, especially when seen through the migration lens, because the remittance flows, which are an important source not just for revenues for the countries, but the source of income for the families, they are expected to decrease by 20%. Add to this decrease in foreign direct investment and decrease in stocks of multinational companies or private equity. This is going to be a difficult year, and moving forward, multiple years. Now, when we talk about migrants, who is a migrant? There's no universally accepted definition of the term migrant as per the International Organization of Migration. So it's an umbrella term which reflects the commonly understanding of any person on the move who moves away from her or his place of residence, either within a country or across an international border. It could be temporarily or permanently, and for a variety of reasons. So these include some migrant workers. This is generally economic migration. This could be for purpose of education, that are students, people displaced because of natural and human-made disasters. So they are the refugees and asylum seekers. So irrespective of their status. So it's a broad term. So if we look at migrants, there are multiple typologies and includes a huge range of human populations and settlements. However, there are international treaties and resolutions which protect the people who are on the move. And when we talk of the COVID-19 response, it's important to walk the talk on migration. So be it the International Covenant on Economic, Social, and Cultural Rights, or the World Health Assembly resolutions on health of the migrants and promoting health of refugees and migrants, it's very, very important to include migrants in our COVID-19 response. It's a busy slide. Basically, what it says is that there are 272 million people globally who are migrants, and almost half of these are women. Closer home in Sri Lanka, we have a net migration out of the country, though increasingly we are getting also inbound migrants. So in Sri Lanka, it's around 500,000 people who have net, there's a net efflux out of the country. If we add to this the internally displaced people and refugees globally, we are adding almost 75 million more to this number. And in Sri Lanka, as of December 2019, there were around 27,000 IDPs. And as per the latest UNHCR reports, there are 980 refugees and 285 asylum seekers currently in Sri Lanka. If you look at the Bureau of Foreign Employment, Sri Lanka has been one of the countries which is sending migrants out to various countries, and there was an uptick until 2014, and there was a slight decrease 2015 downwards. And one of the important factors to look on this slide is the foreign remittances. So we have almost $1 billion cutting into the country as revenue. This is 2017 data. If we look at 2019 and 2020, this would be far more, because 2019, the foreign remittances in South Asia were one of the highest. So if you look at the COVID-19, how is it impacting people on the move? So it's not just one crisis, because we are the medical fraternity, healthcare workers. So we look at health, but when you look at migrants, they have this triple burden or triple crisis that's unfolding in their lives. One is the health and the humanitarian crisis. So migrants generally, they do not have equal access to healthcare in the countries where they are residing because of the status, and it also depends on in what spectrum you are employed. Highly skilled migrants may have better protection than those who are low skilled and are at a lower level of jobs. So most of the migrants, they are not included in the public health services. And generally, especially the economic migrants, they go for low-skilled labor class. They are living in unsanitary and crowded settings. And if we look at the second wave of COVID-19 in most countries, like Singapore, it was largely in migrant workers, or in the Gulf Cooperation countries, most of the numbers are actually coming from migrants living in those countries. Then there is the economic or the socioeconomic imperative. So the World Bank estimates are that 60 million people would be pushed into extreme poverty in 2020 alone. And cumulative, the ILO estimates are that 400 million people jobs would be impacted. So there'll be a drop in the foreign remittances, as I just mentioned. This would be important not just for the economic recovery in the country, because the countries would be more dependent on these remittances, but these are workers who are returning back. There's an important factor in terms of looking at not just their health and economics, but also reintegrating them into the labor workforce. With unemployment rising, that can lead to social incohesion. Most of these workers, they lack income security, that especially for women workers who are migrants, especially in the place where they are employed, they suffer gender-based violence. We have reports coming out of the UNFPA that during the COVID-19 pandemic, the gender-based violence has actually increased. And again, these people are not able to access the support services that are available to the native population. And with women, there's also high risk for children because there's increased risk of child labor and child marriage to get out of the socioeconomic distress. Then there is the third crisis, which is that of human rights and protection. This is especially for people who are migrants and refugees that are displaced from their home countries because of various factors. There's a lot of xenophobia and stigmatization. This thing about migrants bringing in the disease, or they are spreading the disease, and border closures, making no exceptions for asylum seekers, so there are no humanitarian corridors through which these asylum seekers could come. There is more and more inward-looking policies. The whole international order has been disrupted. And then, again, most of these people who are seeking asylum or refuge, they are generally in overcrowded facilities with little access to health services, where chances of spread of the disease is very high. So if we just do the vulnerability and risk mapping, this is important because moving forward, if we have to look at the mitigation measures, and this is from a IOM report on the migrants in the COVID-19 epidemic. So if you look at the vulnerabilities, as I mentioned, because of crowded settings, linguistic barriers, poor access to healthcare facilities, and continuing exposure and limited personal protective equipment in the workplace, the migrant workers are at high risk of contracting COVID-19. And because of poor physical distancing, there's also a risk of super spreading events where these migrants are living. Then if we look at the social protection measures, because these people are not covered, especially those that are undocumented and are low-skilled and are working in unorganized sectors, they are more vulnerable because there is no social protection, no safety nets. They have limited awareness to top it in terms of what are their rights in receiving healthcare. Language barriers may prevent them accessing healthcare in the countries where they are residing, and they may be unwilling to come forward because of fear of arrest or stigmatization. Then migrants also have high risk in terms of pre-existing respiratory diseases because of occupational exposure, because of the living conditions, and inability to access timely assistance. So their risk of having severe disease of COVID-19 is also high. Then staying away from families, especially when there are lockdowns, travel bans, there's isolation, when inability to communicate. There could be obstacles, especially if a loved one has passed away and proper burial is not possible. Then there could be anxieties related to being stranded in foreign land, not able to return. And we have seen here in Sri Lanka those desperate calls of the migrant workers staying abroad to making pleas to the highest level to come back to the country. Then in terms of livelihood and income insecurity, because these are the people who would be losing their job first, because when protectionism comes, the native populations are protected first. The first ones to be kicked out of work would be the immigrant workers. So what can countries and societies do in terms of taking care of the migrant populations? And here I would just like to pause to say that while we talk about international migration, largely when we talk about people on the move, it's very important not to forget that there's also migration that happens within the country. And actually, national migration is almost 2.5 times that of international migrants. So these are people living in rural and peri-urban areas who come to the cities for work. And this is the lifeline for the households for subsistence. And these have been ruptured because of lockdowns and complete disruptions of economic activity. And that has pushed people into poverty. And add to that, school closures, lack of access to education, and other alternative means of living, these people have been pushed into deep poverty, and especially because their safety nets were already very low. So, in terms of what can countries do, we cannot have a COVID-19 comprehensive response without taking into account the needs of the displaced populations, be it within the borders of the country or cross-border. This would be very important in the recovery, both health as well as economic recovery of the pandemic. And we will need scaled up preventive measures to look at, especially wherever there are refugee camps and informal settlements, to ensure that the disease does not spread, that these people are given all that is needed to take care of themselves and their societies. We have to ensure economic assistance and social protection. So whatever that is being given in terms of economic assistance, it's important that that's also extended to migrants. In terms of healthcare, it's important to have some kind of health insurance for migrants. We have seen that most of the time these people are in settlements with poor access to healthcare, and there are also not only contracting the disease, but there is also a potential of spreading the disease. It's important to have a proper communication and engage the migrants in all the communication strategies, so that this will take care not only of the xenophobia and reduce stigma and discrimination, it will help in having a more culturally sensitive response to the migrants. And very early on in the epidemic, like we were reached out by our offices, especially in the Gulf Cooperation countries, to have the materials available in local languages, because those migrants, whatever was being produced, mostly because that's in Arabic, while the migrant workers do not speak and understand that language. So that was a good cross-border collaboration that happened. And especially in terms of the humanitarian assistance, it's very important to have open humanitarian supply corridors, because with the complete rupture of the supply chains, it became very, very difficult to provide the needed equipment and the consumables that were needed for the pandemic response. Last but not the least, it's very important that migrants have made a huge contribution to the COVID-19, especially those healthcare workers in the front lines. If you read news from across the globe, they have given up their lives in the pandemic response, and they are very, very critical. And we need to also harness the capacities of these migrants in the recovery, both for health as well as the economic recovery. I would just like to end by the slide where the UN Secretary General, because he has been really pained by the plight of the migrants globally and largely in the humanitarian context. But he's given this these are the 4 tenets, as he says, for ensuring a global response which is grounded in solidarity and responding to the needs of the migrants. It's important that it's important to understand, if we exclude, it will cost us dear. If we include, we'll have a payoff. And it would, to emerge stronger from the both health as well as economic disruption, it's important to include people on the move in our recovery plans. And the response to COVID-19 and protecting the human rights of people, they are not mutually exclusive. That we have to have a response which is right-based, inclusive, and it is our collective responsibility to protect people, especially those who are fleeing the horrors of war and persecution. And no one is safe until everyone is safe. And people on the move, they are not a problem, they are part of the solution. And one thing which, especially for the medical and the health fraternity, it's important, there's a huge demand for healthcare workers. And moving forward, when we plan our mitigation measures in the short, medium, and longer term. So what happened in, say, the global economic crisis was there was people moved on from one sector to the other. So they repurposed. So for example, if construction went down, they moved to agriculture, retail. Now, in COVID-19, what has happened is that the demand is highest either in the health sector or in the IT sector because of rapid expansion of use of digital technologies. Now, those are high-skilled jobs. You cannot repurpose from one to the other. So it would be important to look at actually international cooperation on how this is a good time to look at the global shortage of healthcare workers and across all cadres of healthcare workers, so that in future, if we are looking at a globally secure and resilient world which can manage pandemics and other disasters, that this is a time to look at how do we shape the global health and human resources. That's my last slide to say that global coordination and cooperation is critical. This will help not just addressing the pandemic, but also in the economic recovery. And it is our greatest chance not only to achieve the public health goals, but also enable a robust global recovery. And as our Director General, Dr. Tedros, he always ends his media briefings by saying national unity and global solidarity. Thank you very much.
Thank you, Dr. Razia Pendse. If you may stay a little while if there are any questions. Now, again, the forum is open for discussion and questions. If there are any questions from the in-studio audience, you may ask, or otherwise, online participants can send their messages. While questions are coming in, if I may ask now, yesterday during the day one, we had a very interesting symposium sharing the experiences from different countries, lessons learned related to COVID-19. And Singapore was very specific, how they had the second wave related to the migrants. Initially, the Singapore was the kind of poster boy for COVID-19 management in the Southeast Asia, but later they were somewhat badly hit by the second wave due to migrants. So Sri Lanka probably may not have the same number of in-migration like Singapore, but we have a lot of Sri Lankans who have gone out-migrated. So what do you think about the Sri Lanka's role so far related to managing this issue related to migrants? What are the positive areas and what are the areas that are for improvement?
I think so. That's a very good question, Professor Indika. In Sri Lanka, we have had repatriations, and the flights started pretty early, even during the lockdowns. And there were also some amnesty flights that were coming from sending countries. And in terms of ensuring safe landing, safe holding, as well as safe integration into society, I have to say that Sri Lanka has done well as for the overall COVID-19 response. And I think so we have over 50,000 who are expected to return in the next 3 months. And overall, there may be, I'm told by the IOM that it could be over 1 million people who would be wanting to return to Sri Lanka, if not permanently, but temporarily. Now, it's important because Sri Lanka has had this policy of whoever comes in to do the PCR testing, to keep them in quarantine, and quarantine for 2 weeks, which is compulsory quarantine, and then 2 additional weeks so as not to miss out on any late bloomers. So, and there where physical distancing was not possible, they are actually kept in the quarantine centers. Now, that's a huge investment. So for a country with modest resources, there has been a huge investment in ensuring that those people are there. We have seen the numbers, and every day if we look at the numbers, okay, we had these 2 clusters coming, the Navy cluster, the Kandakadu, and before that also we had the Suduvela clusters. But when the returnees happen, we have positives coming in, because even if they are coming with the PCR test done, we know that there could be 20 to 40% of false negatives. That's why to have those facilities to do that and to put them in isolation facilities, because most of them fortunately are asymptomatic or with with few symptoms. But at one point, with one particular batch that had come, that people were severe, and that's why they took the decision in terms of having the bilateral negotiation, so that we could have a safe entry into the country. And now the country has managed to negotiate with many sending countries on exit screening. So until now, we have been able to manage well in Sri Lanka, and hopefully in the future, I mean, we will not be able to stop, because virus anywhere is a threat everywhere, and that's why we have to keep our guard up. We cannot let it down. But until now, Sri Lanka has done well. Thank you.
Thank you, Dr. Razia, for that very kind comments about the Sri Lanka's approach. Dr. Sajid, you want to ask a question?
Yeah, what would be the strategies or plans like for the non-skilled migrants in future? I personally believe in future, in a pandemic like this, if it is coming again, what would be the plans for the non-skilled migrants? Because a lot of migrants who have gone abroad, and they were putting a lot of comments and videos, bring us back to Sri Lanka. So likewise, so what would be we have to have a backup plan in a case like this in future. So what would be the backup plan for the non-skilled migrants?
Well, this is mainly, I mean, with the government of Sri Lanka and its IOM and ILO, they are working very closely, because from the WHO is having, to keeping them healthy, and if they have the health conditions, to give them access to health services. And then it's important because there will be a lot of retooling and reskilling that would be needed. So some would be coming already with skills that could be integrated into the societies, and they could be part of the economic recovery. And for others, see, at the end of the day, this is a human resource, and Sri Lanka is an aging country. So any young, human resources coming into the country can be used to the advantage. But I think so even the 14 days in quarantine, or if it's an extended 20 days, could be used for having those skill labs, so that they could be done in centers where the upgrading or the retooling and reskilling would be there. By the time you can find where these people would be absorbed, because there's a lot of now reflection in many countries to look at self-reliance, because of the disruption of the international supply chain and the market-based or the capitalist economy. So that would be important, and I think so it should be looked at as an opportunity. And as I said, they are part of the solution, and it should not be looked at as a problem. Thank you.
Thank you, Dr. Razia. And we have some time left for discussion, which is actually a good thing. Any questions, comments from the online participants would be very much welcome. You can send messages or just put your hands up, then we'll be unmuting you so that you can comment or question from the online, either Sri Lankan or international participants. Yes, please.
I thought we had finished the time or something. Have your attention been drawn to a very important, I haven't seen it in any media recently, the Rohingya migrants were treated very badly here, and we came into the news, and I follow these things, but recently no media has drawn attention to where they are now. I know they were removed from one place to another place. Does anyone know about that? That's a migration problem for Sri Lanka. Very acute, yeah.
Again, that is the UNHCR
Rohingya,
mandate.
yeah.
Because anybody who comes in, whether they seek a refuge or asylum, and as I said, the number of asylum seekers and refugees currently are few, because we have over 1,000 people who are in Sri Lanka. And the issue that you are talking about initially, yes, there were these issues, and UNHCR had taken note of it and had worked a solution with the government of Sri Lanka, and they were put in camps, and many of them have already their papers have been processed for onward movement into the countries who had accepted them as refugees or as asylum seekers. I don't know, but maybe if I have more information, I'll be able to pass on. But in recent times, I have not heard of that crisis unfolding. Thank you.
I think
Uh, one more question. Again, a lot of questions from Dr. Razia. Now, you said that Sri Lanka has done a very good job related to the managing even the inbound migration, and there are a lot of migrants who want to come in during the initial period also. And some of them, like you said, they were found to be positive, and the positive rate was higher than that was found in Sri Lanka. If Sri Lanka has to bring them in larger scale, do you think the country has a capacity to manage it, or would that be challenging, or would that lead to reversal of some of the achievements or kind of the control that Sri Lanka have been having? That any suggestions?
So that's why it's important to plan, because if we have a planned entry of people, and if we are able to do the quantification or to do the projections, how many people are coming, and if they are positive, and what's the trend. As I said, there was only one batch where we had actually sick people requiring intensive care. The rest were largely asymptomatic or with few symptoms. So if we are able to, and currently the one of the metrics that's used for controlling inbound migrants, actually repatriations and returnees, is the capacity of the quarantine centers. So that would be, it would be important. Plus, I think so one other adjustment that was done was, instead of having hospitals for more clinical management and high-end intensive care, to actually look at hospitals with isolation facilities, because that's where it was needed. So there are these adjustments that would be needed. What is most important in the in the COVID-19 pandemic, is that we are learning about it every day. So we need to be agile and nimble, and we need to adjust our response based on how the situation is unfolding. So if we are able to have a more regulated flow, influx of people, that the system is able to manage in terms of diagnostics, in terms of hospitals, we should be able to manage it well. Thank you.
Thank you, Dr. Asia. And now we have come to the end of this session, and Professor Miki Chopra has already left because it's very late at US, but he has sent his congratulations to the SLMA, World Bank, Ministry of Health, and the WHO for work done. And what he has suggested is regarding online learning, to make it customized and based on the needs, to make it that it's more marketable and based on the needs of the medical officers. Actually, we have done it once during this COVID situation. The online program that the Ministry, SLMA, and WHS launched, we have done one module related to management of NCD in the COVID-19 situation. And one thing we have noticed was that participation was very high for that webinar, comparative to other modules that were custom built and routine. For this seminar, the 100% participation was there. So I think there are a lot of things that are happening, and there are a lot of things that we can do. Any more comments from either Dr. Deepika or Dr. Vindya before we conclude?
Thank you so much for organizing this. As you said, the final the webinar that we have organized through this distance education platform during the COVID, I think, as you very correctly mentioned, a lot of participants were there. But we need to maintain the momentum, because once the COVID is there or not, this new culture need to be sustained. We need to support them. So this distance education, learning with the different modalities, would be a felt need of the country. And so we are there to support the SLMA and the ministry. You need to take the lead. I'm sure the WHO with the World Bank and any other development partner would love to help the country to move forward with this new normal. Thank you so much.
Can I just add to that? I think so it's important that use of IT and digital learning solutions is going to be the way forward. We'll even if we move out of the COVID-19 pandemic, this is an investment which should be sustained, because moving forward it will help, because the next we are already facing is the climate change. And if we can reduce the number of people who are traveling, and we can have more and more, so like work from home in most countries is becoming now a kind of established procedure. It would be also important that while we look at continuous professional development in the in-service category, to also look at the pre-service. because now with universities and closure of schools, there's a lot of online, school and classes that are there. The other thing with a skill-based training like the healthcare training, perhaps it would be good to invest in skill labs, that so that there could be practical training, because that's where the most it's most problematic, because we can have a very good online platform to give knowledge, but to develop skills. So that is something that it would be good to look at, and it would be a worthwhile investment moving forward. Thank you.
Thank you. And Dr. Padma, joining from WHO country office, want to comment. Dr. Padma?
Can you hear me, Professor
Yes.
Vindya?
Yes.
Okay. Thank you very much for giving this opportunity. I think this only highlights the capacity for someone from a distant area also to link in like this, because on building on what WHO had been saying, and WHO has been sort of supporting the to digitize the learning management system of all basic training institutions in the country. That's about 48 training facilities. And at the same time, most of the in-service providers in the Ministry of Health, like the NCT Directorate and what was Dr. Vindya telling about, and the Family Health Bureau, the Healthcare Quality and Safety Unit, then the National Institute of Mental Health and National Institute of Infectious Diseases, the blood transfusion services. We will be supporting them to digitize their learning management through electronic learning management systems and webinar platforms. That's already have been begun. So just to add on something that we have commenced with the Ministry of Health with donor agency support and WHO technical expertise. This will not be just hardware support, but we will be giving capacity development support in making online training modules for all these, where the idea is that we can at a later time, Sri Lanka can be a knowledge hub that is contributing to the WHO academy, which is already there, free to all, so that we have a safe, more effective, and far-reaching learning management system that any healthcare worker or anyone in the country can tap onto. Thank you.
Padmal, may I ask my co-chairperson, Dr. Jayasundar Bandar, to make his final remarks?
Say as a whole, we had a very good session today. Professor Dr. Miki Chopra started with his international experience, and then Dr. Vindya presented what really experienced in Sri Lanka for NCD, especially the COVID-19 during COVID-19, how NCD was managed, the program was managed, and then the last Dr. Razia Pendse, our WR, she in fact elaborated the global scenario and in fact local scenario too, on the migration and the impact of migrants and the COVID-19 and the migration, the relationship. And in fact, why congratulating to all three presenters and to the participants both locally and online. I make a request, Razia. I think the WHO has a very good study to do in the coming months, because in the globe, the COVID-19 has affected almost all the countries and the countries. But then each country, how they looked at COVID-19 and how they sort of tackled COVID-19 was quite different. Now, I know, being the project director for this COVID-19 project in Sri Lanka, how much Sri Lanka has to spend daily to maintain these quarantine centers and manage those who are not really positive, but just to sort of safeguard the other community. This is expensive. But still, a country like Canada, I know because my daughter is in Canada. But Canada, various provinces, say if you take Manitoba and Calgary, both provinces are, very much different. And the impact is also different. So while, the Canada government, what they did at the early February or January, they presented the guidelines, the general guidelines for the public, and advised the public to keep all these social distancing and home quarantine, if there is, and established a lot of testing centers. in the street centers. But then ultimately the number of casualties and even number of deaths are much more than Sri Lanka in those countries. So will the WHO do a study, the benefit and the strategy, so that that will be very much valid and important for the other countries even in the future global pandemic. Thank you.
Thank you, Dr. Jasana Bandara. Actually, we have already started that, and we would be documenting the Sri Lanka response to the COVID-19 because it's an important learning, not just for the country, but for the global public good. So we've already identified a writer who's working closely with the Ministry of Health, and hopefully we'll be having that story in Sri Lanka soon. Thank you.
Thank you very much. And with that, we come to the end of this very important session, a very informative session. I think the way forward, a lot of areas were discussed. And I thank the WHO, Ministry of Health, and the World Bank for co-sponsoring and supporting this very important session. Thank you.
Thank you.